Good morning. Welcome to the first webinar for clinical genetics. We're going to focus on the clinical genetics EQAs, but we will also discuss some other aspects of GenQA which may be of interest to the clinical genetics community. The EQAs themselves ensure the quality of the entire genetics service as we cover both laboratory-based EQAs and the clinical genetics aspect of the service. This webinar will cover a description of what external quality assessment actually is. We sometimes refer to it as EQA, why EQA is important and what the benefits of EQA are. We will also explain who GenQA are and the format of the clinical genetics EQAs and how they work in practice. As part of this, we will show you an example case scenario from a recent EQA. Genomics is always changing and EQA has to adapt. And last few slides will discuss the future of the clinical genetics EQAs and how we are adapting to change. What is EQA? Well, EQA is the external validation of the quality of a service according to international standards. It provides centres with an external measurement of the standard of the service to users, such as clinical users, laboratories, commissioners, research and development parties, and clinical trials. And this external validation gives confidence to the users of the service that the centres are meeting the international or local standards. The aim of EQA is to improve the quality of care. It is educational. It is not there to judge centres, although it may seem it at the time. It is purely educational. Why is EQA important? Well, it helps to harmonise the quality of the clinical service and also promotes quality across national borders. It can ensure that family members are counselled appropriately and where there are international standards that they are counselled in the same way. EQA can be an external verification of the clinical service as it identifies imperfect practice and improves quality where there are issues. The way the EQA is set up will identify the following inappropriate approaches to genetic counselling. If a clinical geneticist does not recognise the clinical features of a disorder, they may request the wrong tests and the disorder or disease is not diagnosed. If a clinical genetics centre has an analytical or interpretive problem, they may report an incorrect result. And if a clinical geneticist or counsellor incorrectly interprets the laboratory results, this may result in a patient receiving an incorrect diagnosis or incorrect prognosis, which may compromise their treatment and therefore their overall survival. So who are GenQA? GenQA stands for Genomics Quality Assessment, and we're a member of the UK NEQAS Consortium, and this is the home page of our website. GenQA is a member of UK NEQAS. UK NEQAS itself has been offering EQA for over 50 years, and so that wealth of experience is available to all the members of the UK NEQAS Consortium. There are over 25 specialist centres in various areas of pathology. All the EQAs are ISO 17043 accredited, and we have participants worldwide. UK NEQAS is a charity organisation. It is self-funding and not-for-profit. GenQA has been offering EQA since 1982, and we offer more than 100 EQAs for both genetic, pathology, and clinical genetic centres. We also provide a training and competency tool called GTACT. The GenQA offices and laboratories are based in Oxford and Edinburgh, and we are the largest genomics EQA provider. And as you can see from this world map, all the countries in green are the countries we currently have participation in for 2020, including Japan. The countries in grey we do not currently have participation in, but you can see they're of the low economic countries, predominantly in Asia and in Africa. The clinical genetics survey was carried out by the ESHG board and quality subcommittee as they recognised there was a need for an EQA in clinical genetics. And in 2012, this survey was sent to 32 countries and 22 returned the data. The 22 countries are shown on the right. In more than 3/4 of the countries, less than 100 clinical geneticists were working. And in these countries, there were less than 25 genetic counsellors at this time. Certification for clinical genetics was only mandatory at this time in 3 countries, and postgraduate training, where it was available, was only every 3 to 5 years. So as an outcome of this survey, the ESHG Quality Subcommittee tendered the European EQA providers for an online clinical genetics EQA, and they gave the tender to GenQA. So in 2014, the first pilot EQA for clinical genetics was introduced. So GenQA is quite unique in that it offers end-to-end testing. First of all, we have when you have a patient, there is a pre-test referral, and it might be a consultation with a clinical geneticist or a genetic counselling. The sample will then be sent to a diagnostic laboratory where the DNA may be extracted, it will be checked for quality and the quantity. You'll then do the analysis, interpretation, report the result. And all these processes are covered through EQA, all the separate processes. In addition, after the results have been sent to the clinician, there'll be a post-test consultation, sometimes with a clinical geneticist. And GenQA covers both the pre-test and the post-test consultation through the educational clinical genetics EQAs. So GenQA is able to say that we cover end-to-end testing right from the start when the patient goes to the clinic to the end when they're counselled as to the results of the investigation. The format of the clinical genetics EQAs is based on a real patient referral, and a case scenario is made by the clinical geneticist, which includes the expected learning outcomes. The case scenarios may be pre or post-test counselling. The case scenarios start with a referral letter from a general practitioner, although this could be another clinician. The case scenarios give images of patients, the family history, and other relevant information. They will also include test results with interpretation for any post-test counselling EQAs. The clinical information is given sequentially with questions, as perhaps you might see in a real case. And you're expected to submit your answers to the questions at each stage online. And once you submit your answers to stage 1, you will be able to see the stage 2, but you won't be able to see any details of the next stages until you've submitted to the previous stage. You can review the previous stage once you've submitted the answers, but you cannot change your submission. There is an option for you to save and to come back, but you will still not be able to see the next stage until you've actually submitted the answer. Once the EQA is closed, the submissions are assessed by assessors and they feed back to the centres on the expected versus submitted answers. and give any recommendations within the summary EQA report. It is then hoped that the individual centre report and the summary EQA report will be reviewed by the centres and looked at to see if there is any need to change practice or the way a patient is counselled. And hopefully this will result in a quality improvement by the centres if the service currently given has some imperfections in it. The timeline for the clinical genetics is very simple. The case scenario opens in October and will do this year despite the pan-epidemic. The closing date is in December. The assessors meet to review the submissions in January. In February and March, the results of the EQA are released. There's then a process of appeals where centres who perhaps consider that they have not had their submission marked correctly or fairly can appeal. And then we review those appeals, either adjust the marks or explain why the marks were deducted. And a final report is released in April, and the participation certificates are released at the same time. And the image is of an individual centre report. The clinical genetics EQA participation has varied over the years. There are 4 different clinical genetics EQAs. There's cardiovascular, dysmorphology, monogenic, and oncogenetic. And the reason for this is because in 2017, a fee was introduced. Previous to that, it was free. And you can see in all cases that the EQA participation therefore dropped, but it is now rising. And currently, the EQA for 2020 is open until the 3rd of August if you're interested in participating. There are 4 different clinical genetics EQAs: monogenic, dysmorphology, oncogenetic, and cardiovascular. And over the last 6 years, these are the syndromes and conditions that have been given to participants. All the case scenarios are based on a real patient referral. And I'm going to spend a little time explaining the case scenario for Mowat-Wilson syndrome so you can see how an EQA works in practice. In the dysmorphology case scenario presented here as an example, there are 3 stages, and at stage 1 you are given the request form, growth chart, family tree, cerebral ultrasound, the normal male array result, and the clinical pictures shown below. In addition, from the referral letter, you know that the child has corpus callosum agenesis, an operation for Hirschsprung's disease, feeding problems, hypotonia, and developmental delay. And with this information, you are asked to describe the dysmorphic features in the patient's photographs and to give your differential diagnosis. Given this information, the expected answer was Mowat-Wilson syndrome, and all centres included this within their differential diagnosis. At stage 2, you were then asked what additional non-genetic investigations you'd recommend to the paediatrician based on your diagnosis, and to provide at least 3 important referrals to other specialists at this stage and give your reasoning. And then you were also asked what genetic testing you'd perform and specifying the genes and technologies. In stage 3, you have requested a paediatric neurologist evaluation, and the child had a brain MRI, which showed complete agenesis of the corpus callosum and hypocampal abnormalities. Now, if in the previous stage you didn't request the correct evaluations, then in stage 3 we've given you the correct response and therefore you can still continue to answer the questions. So this is the educational benefit of this EQA. You're also given the molecular analysis of the ZEB2 gene, and there's a frame shift variant in exon 8 of this gene found in the proband, but no pathogenic variant was found in the parents. And you're asked to list at least 5 main topics that you're going to discuss with the parents concerning the clinical consequences of this diagnosis in their son that is relevant to this case scenario. You're also asked to discuss with the parents the genetic consequences of the diagnosis, and this should include the recurrence risk. The general observations for this case showed that only a few centres considered the possibility of further testing or re-evaluating the differential diagnosis if the sequencing, NGS or MLPA results were normal. This is probably because the child showed classical Mowat-Wilson syndrome. But in any clinical referral, you need to be aware what to do when the diagnosis results come back normal. And in 1% of referrals, a patient may need to be re-evaluated clinically and further genetic testing undertaken. For instance, an NGS panel for other syndromic conditions with intellectual disability or developmental delay, or methylation-specific MLPA for Angelman syndrome, or whole exome genome sequencing to analyse the various causative genes. And only a couple of centres did do this, and so we picked this up on their individual centre reports and also in the summary document so that we could educate everybody into considering other options. The general observations from these 4 EQAs were as follows. In many cases, insufficient information was requested on the proband's birth, behaviour and/or clinical features. For the dysmorphic EQA, not all the dysmorphic features were identified, which could compromise the differential diagnosis. For all the EQAs, a 3-generational family history was important, as was to ask for the counselee if she had any signs of cancer in the oncogenetics EQA. When it came to the diagnostic phase of the clinical genetics EQAs, a gene panel testing was not always considered when it was available in those countries, nor was consent from the index patient before approaching relatives. And finally, there were a few centres that suggested testing in minors, which wasn't applicable for the case scenario, as there was no medical reason for doing it. The implications of the recessive inherited disorders were not always comprehensively given for the patient or proband, and the different phenotypic expression of the same genotype wasn't always explained fully, and some centres had comments because of this. Likewise, the reproductive options for the couple were not always comprehensive, and sometimes only prenatal diagnosis was suggested when other options were available. And for the post-test counselling, giving a population recurrence risk was inappropriate for the couple, and so some centres said 25% was the recurrence risk instead of giving an individual risk for each child, which is 1 in 4. The importance of pre-test and post-test counselling in healthy individuals for some genetic conditions was also omitted. And for all the EQAs, we did note through the patient groups that psychosocial support was often omitted. Once the EQA has been assessed, the centres will receive an individual centre report, as can be seen on the top right. They will also receive a summary EQA report, which is anonymous and will show the results of all of the centres, and it gives you information about how people reported the cases and where there were omissions. And this is very educational for all centres. There's also a participation certificate, And you can look at the EQA summary report to see how your scores and your answers compare with the expected answers and with other centres. And then you can review how you've done and check whether or not there is any room for improvement. There may not be. So EQA overall improves the clinical service, and we've seen this over the years. It helps identify weaknesses in the centre which they can improve upon. And EQA participation should be annual, as for each year we have different case scenarios, different disorders or diseases, and it's important that you participate in all of them. To summarise the Clinical Genetics EQA, it is educational. There is no performance designation, such as poor or satisfactory, because it is educational. This may come in the future, but currently we're not planning to do this. I now want to talk about the Training and Competency module, GTACT, which is also part of GenQA. But this is for individuals, not for centres. There are multiple modules, we have different runs. It is again educational, and you either pass or you fail. And if you look at this slide, you can see the different modules that are available. Many are laboratory based, but some are relevant to the clinical service. So sample reception, duty scientist, report authorization, test data analysis are all lab based. The tumour content assessment is actually clinically based, about actually working out which part of the section has tumour material. The clinical interpretation for sequence variants has been very popular, and this is in classifying variants whether they're pathogenic or benign for both CMVs and SMVs. And very recently we've introduced a COVID-19 module for PPE in care homes and also for molecular testing. The BRCA1, BRCA2 variant classification for the first run in 2018 gave centres 15 variants to classify. As you can see from this slide, there were 8 variants that were class 5, 2 variants class 4, 3 variants that were class 3, 1 variant that was class 2, and 1 variant that was class 1. Why is this important? Because if you have a class 4 or class 5 variant, you would be offered PARP inhibitor therapy. If, however, you have a class 1, 2, or 3, then you would not be offered PARP inhibitor therapy. So this is a personalised medicine. And the results showed some variation, but this is the first run. But this variation would change the clinical management and treatment options for these patients if it was a real case. The black dotted line is the cutoff for whether you get PARP treatment or not. Classifications 4 and 5, the treatment would be given. But for classifications 3, 2 and 1, no treatment will be given. The bubble chart shows the expected classification in bronze. Other classifications are in blue that the centres provided. Now for variant 5, you can see there is a discrepancy. You can see that the expected answer was a class 4 variant. However, a large proportion of centres chose to make this a VU, and for those centres, this patient would not receive the appropriate treatment. The size of the bubbles reflects the number of centres that said a particular answer. If you then look at the classification for 13 and 14 variants, you will see that in this case, the vast majority, although a small proportion in both, did not report this as likely pathogenic or likely or pathogenic, class 4 and class 5, and there's a small proportion that reported it as 3. However, in the variant 14, more laboratories reported this as a class 4 when actually it was a class 5 variant. As genomics is a constantly changing field, EQA also has to adapt to change. And with the recent epidemic, that has also created a situation where the EQAs have had to adapt to change again. And this is more to do with logistics. So we have introduced some COVID testing modules in GTACT, but also we've had to change our timetable. For 2021, the Clinical Genetics EQA will open in October. The Clinical Genetics EQAs have not been affected by the COVID-19 pandemic. We have a plan for rotation of disorders for the next 5 years. We also plan to introduce pass and fail categories and will prepare performance criteria. In addition, there are discussions with the European Union of Medical Specialists to recognise these clinical genetics EQAs for CME. In the future, we are hoping to offer a GTACT module for construction of family pedigrees. From September, you will notice that there has been a reformatting of the website and the documentations have also changed. So there is now a general information document for EQAs, and there are also specific documents for clinical genetics, hematology, and other disciplines. The one shown here is for hematology. The referral cards and the summary EQA report have also been improved. And so we hope you will enjoy these changes and find them much more beneficial. So to summarise the benefits of EQA. EQA has a surveillance role. It helps to assess whether centres are adhering to international guidelines and international standards and picks up where that is not happening. It enables centres to compare themselves against each other and against standards and may also help refine best practice. It's educational. It aims to improve the overall service to the user. It validates the service with respect to quality and helps to bring public confidence, and it can identify gaps in the service that's offered and the internal quality management system. Now that's a benefit for all EQAs. For GenQA in particular, we have educational EQAs, such as the clinical genetics EQAs, the individual training and competency modules, the GTACT modules, and we also have webinars. And annual participation in EQA is both essential and beneficial as the syndromes change each year. We would like to thank our clinical genetics colleagues from different countries who have helped to prepare and to assess these 4 EQAs. For dysmorphology, Livia and Sophia. For monogenic, Karen and Tommy. For oncogenetic, Christy and Thomas. And for the cardiovascular, Borat and Andrew. We're very grateful for all their input. And also from the patient groups who give us input onto the case scenarios from a patient perspective. So we look forward to continued collaboration with the clinical geneticists and the patient groups so that we can keep producing these EQAs. Thank you.
I'd like to thank Ros for that very clear overview of the clinical genetics. If you've got any questions, you can ask these questions online. and one of us will be pleased to answer your questions. I have one question, Tommy, that's just come up. One of the questions is, how do you choose which clinical cases you're going to use for EQA?
So in the past, what we have done and what we're probably going to continue doing is to choose a case which is probably typical for a condition and which at the same time would be educational. We use the more common disorders, as you saw from the list, and these are things that we believe that clinical geneticists should be able to answer. The questions are what we believe they should be able to answer. And in formulating the questions for the coming year, we also look at one or two aspects that have been a problem in prior years and trying to re-put them forward so that people get used to these tasks. These clinical genetics EQAs have all been center orientated till now, but as Ros mentioned, we are negotiating with the European Union of Medical Specialists at the moment to get accreditation on individual level. This goes probably hand in hand with what the European Society of Human Genetics is doing now in giving one-off exams for clinical genetics, but there is no follow-up. And so in negotiation with members of this European Society of Human Genetics committee, we are looking at changing or having available also individual exams. So I think that will covers part of what we are doing at the moment.
Okay, thank you, Tommy. I've got another question here that maybe Ross can answer. The question is, have you had or have you asked for any feedback from the participants as to how they appreciate the EQA?
We did initially, but we haven't done recently. Actually, that's not true. We have done recently. We did it through a generic survey to all the participants for all the EQAs, and we did have feedback from the clinical genetics community, and we have been introducing some of those changes as a consequence. But I think as we go forward and make more changes, we need to continue to ask for feedback.
Okay, and another question, if the participant doesn't understand or agree with any of the answers provided in the EQA, is there a way that they can seek to have more information or appeal the decision?
Yes, after every EQA, there's an appeals process. You have 2 weeks in which to submit your appeal. This will then be reviewed by the SAG, which consists of all the clinical genetics assessors, and they will decide whether or not the appeal should be accepted, or if they don't agree that the appeal should be accepted, we will give reasons why we haven't agreed with their appeal.
Okay, thank you. There was a question that's probably linked and you probably partially already answered about the oversight of EQAs. And I could perhaps answer this so that although there are assessors involved in each of the individual clinical genetics EQAs, the 4 EQAs are overseen by a scientific advisory group which is consisted of clinical geneticists. These clinical geneticists have got many, many years of clinical experience, and they come from several different countries within the European Union. Currently, there are people from 6 different European countries, and these then agree amongst themselves the case scenarios and review the case scenarios before they go online to the participants. And then at a higher level again, all of the scientific advisory groups are overseen by a clinical advisory board. So that's the oversight of the EQAs. I haven't got any more questions sent at the moment, so we could perhaps wrap up unless anybody else quickly wants to send a question.
There is one question here that says it would be useful to have a similar talk on GenQA NGS data analysis, the bioinformatics, and how germline and somatic schemes are evaluated. And I think I remember rightly, that is actually going to be happening this year. So I will double check that, and if it's not, we will certainly add it to the webinars. So this is just to say that we would welcome your feedback from this webinar. You can still see the webinar on a YouTube channel, and that will be available, and you need to click to subscribe. If you have any difficulties, get in touch with info@genqa.org, and there will be participation certificates sent to all those people who have registered for this EQA and joined us today. And the next topic will be hematological neoplasms. So thank you for joining us. It's lovely to have you participate. Thank you.
Thank you.